The afternoon session, House Healthcare, and we have in Green Mountain Care Board to discuss their budget. And joined by Sarah Foster and Jean Stetter in finance.
Afternoon, Chair Black and committee. Thank you for having us back. Today we'll give an overview of our budget, answer any questions you have, and then we have some information on staffing relating to the potential of the state going forward with the AHEAD model, and also we have some considerations for the outline bill in Senate Health and Welfare relating to some additional healthcare reform things that are on the table currently. I'm the chair of the board, Owen Foster, and I'll let Jean and Susan introduce themselves.
I am Jean Stetter. I'm the Administrative Services Director for the board.
And I'm Susie Barrett. I'm the executive.
So Ms. Stetter will start with an overview of the budget and the ups and the downs.
All right. So this is the presentation. I'm going to quickly flip through this because you've already had the intro. We're going to go straight to our budget slides. So this is the slide that finance management requests that you see for everyone. It's a great format. You know, our mission is to drive system-wide improvements in access, affordability, and quality of healthcare to improve the health of Vermonters. Historically, the Green Mountain Care Board has come out at about 40% general fund, 60% bill back. And that is, we have a specific bill back regulatory fund where we bill the entities we regulate to help fund our budget. You'll notice that there is 3% now for a special fund for the evidence-based advertising fund. And that is, we received new work last year in Act 134 for prescription drug regulation pricing work. And that is funded specifically through that. So that's why it shows up. It shows up here. So going over our budget, I broke out the typical percent increases to show kind of how it all came together. So in our base budget, which doesn't include the prescription drug staffing nor the governor's base incentive, we're up about 5%. Act 134, the prescription drug regulation, we're up there about 14.9%. And I want to explain that. So we were allocated $245,000 for 2 positions. We were exceptionally fortunate that our director of data and analytics applied for that position. She's an expert in state government, an expert in many things. And so having the opportunity to hire a seasoned leader like that, we jumped at that chance. That just means that, you know, because she's at a different point in her career, that she's a little bit more, you know, we exceeded the budget. And I'd say we've gotten everything.
No.
We were
Okay,
more.
okay. So the director that they hired.
Sorry.
Oh, okay, thank you. So yes, so that's why that position is up a little bit more than expected. The governor's office and the administration responded to our request for more positions with $750,000. That is a mix of our standard 40-60 mix of general fund and bill back. And in that, they said that we could request 3 positions from the pool. And then overall, with all those changes, that has us up about 13.6%. Within all of that, really to get to the 5% increase that's right here, what that meant is, like I'm sure you've heard from all other departments, we incurred increases due to the collective bargaining increases, due to the medical retirement, all the increases. So we really had to work to get our budget where it is. And I'm delighted to say that we are about ready to move to our new space in Montpelier after being flooded July of 23. We're about ready to have space for our employees in town. So that is fantastic. And then listing, what our FTEs are. Here's a description here. And then, in terms of opportunities and unknowns, the state of Vermont signed to continue with AHEAD. If AHEAD moves forward, the Green Mountain Care Board would need 2 more permanent positions in FY26 to be able to continue with AHEAD. So it would be the 3 that are requested here, plus 2 more. And in addition, based on our understanding of the roles and responsibilities of the board during AHEAD, we would need an additional 15 permanent positions in FY27, and then also 4 limited service. Moving through, and that's because of the specific work related to AHEAD, as outlined in the model, one other request that we have that we'd like to put forward that was not approved in the governor's rec budget and the administration is a request for 2 F-126 limited service positions for automation. The goal there is that we have been able to hire fantastic younger people doing data and analytics, and they really see the opportunity for being able to automate a lot of reports and really improve the processes and potentially their bandwidth for doing other work. I would also say it would increase our ability to retain them. And those are actually positions that we have been able to hire and have gotten high level of interest in those positions. So we completely understand the extremely limited finances that the state has. And, this is truly targeted 1, maybe 2-year positions that are designed to sunset. We won't come back asking for them to be permanent. The third piece here is we do have a language change that's requested as part of the FY26 budget bill. And what that does is it allows us to have billing flexibility needed for ACO. So as you're all aware, OneCare Vermont announced that it plans to cease operations. That doesn't mean there's a complete hard and fast stop in the work that the board does. There's work to wind it down. And the board also has Medicare only ACOs, but the number of those really fluctuate through the years. So our main statute, and I do have paper copies of that language if you want to see it. Or not.
See it, or you can send it to us
Okay, great.
and we can have it posted.
Yeah, all of the above. It's
Okay.
all, I have paper copies and it's all posted already. So the long story short is our main bill back currently bills percentage, like the 60% that we bill there's a percentage that goes to ACOs, which was primarily OneCare. Because of the change in that, what we have requested is eliminated that percentage to OneCare Vermont, because it's going from having one big one and a couple small ones to an unknown number of small ones. So we've requested removing that language. And in S63, implementing fees for accountable care organizations. So there's kind of two paths. So there's a couple key things to know. For the main statute, taking the ACO out of the equation means there's an increase to the amount that will be billed to the hospitals and the insurers. Because the hospitals paid fees to OneCare Vermont, the majority of the shift of the change, which last year was about roughly $570,000. The bulk of that shift right now in our proposed legislation is going to the hospitals, and with a much smaller percentage going to the insurers. So that's that particular statute change. The reason why we didn't include the ACO fees in this particular piece is that there's also proposed changes to ACO regulation, and it seemed most appropriate based on council's recommendation to keep any fees with the potential regulation changes. Any fees that are billed back to the ACOs would reduce the amount paid by hospitals and insurers. I feel like I've gotten somewhat complicated, so I'm gonna pause. And I'm gonna just pause there.
I'm glad Topper's asking the question, not me. Topper, did you have a question?
Yes. If the certificate of need legislation that's being reviewed by this committee,
Mhm.
let's say that took place and it passed, what impact would that be on this? You've got people that do the certificate of need.
Yes,
I understand, or we understand, it takes a lot of time. So what impact would that be on this request?
I feel like we're going.
Would you be able to use people that you already have? What?
I
Going into the
think
matrix.
if we,
Take a shot. So
Yeah.
two essential things. One, the fees that the care board charges to do CON review would potentially be less, right? Depends on how many we still get. So that would go down. And then also the work that those people would do would also go down. They do other things as well. So one of them is a lawyer who does a lot of the rate review work for insurance, and then also does a lot of work with the hospital budgets and writing orders and such. So I think their time would flex to working on those things more, which are rather understaffed as is. But yes, we'd have less money and we would have additional time for those people to do other things. And I would say that hospitals and independents and others would have more time to do other things as well, because they're not embarking on the process with us.
So what you're saying, it's a wash, it's not gonna have an impact on this.
It would have a small impact. We can get you the amount of money we billed for the jurisdictional and for the CON review. I don't think it's a large amount of money. It depends on the year, but we can send that to the committee.
Yeah, that would be great, because if we do move forward with CON, you have to sort of take into consideration that because you will be doing less CONs, you will be collecting less fees.
I would say it,
But also doing less work.
yeah, I would say in terms of I'm not as worried about that. I feel like it's the right.
So if I understand this, you got so many people working on CONs now. Okay, and if this bill passes, it will be extra staff on that, even though we've kind of supposedly made it easier.
We would anticipate that we have, I think it's 2 staff members that work on CON now, 2.
Okay,
And if we have no CONs in a year, they would have no work on CONs. Now they do many other things as well, but yes, we would anticipate that there'd be fewer CONs to review, for sure. I mean, that's the goal here.
and I got one more question just to help me visualize all of this.
Sure.
Okay, what are the thresholds now you're dealing with? Compared to what, if this bill passes, what they will be, you know, the 3 million, the 5 million.
Yeah, I don't have them all in my
No,
head again,
okay,
but it's roughly, currently they're about, I'd call it about 1/3 of what your bill proposes them to go to. So I think for facilities, it's maybe around 3.5-ish million right now, and your bill goes to 10.
May I just interrupt Alan? a little
Yeah,
bit?
I don't,
We're
trust
gonna,
me.
we're gonna do budget and then
Okay.
we're gonna ask the Green Mountain Care Board to comment on the CON bill that we're working on
Okay,
because we're gonna do some markup on that today.
and it does
Let's-
include this because of the new hires here too, so it does.
Yeah, but it's something to be thinking about when we're talking about, so let's let them get through this. And then we'll go into the other. Woody?
Yes, it's my understanding that there's a gap between the current account of the ACO
Oh, Paramount, yeah.
and the gap between that, where we are now, and the new model that may be coming later on.
Yeah.
You talk about flexibility in your budget. Is that flexibility taking into account the gap between one care leaving or shutting down, and then the ahead model coming on board?
You mean in terms of the work that personnel are performing?
Yes,
Yeah.
and everything else that goes with it.
Yes, so I think the answer is affirmative. There's ongoing reporting requirements even after the current model sunsets. We have ongoing reporting requirements and obligations to the federal government. So there's a tail to the work. Just when the ACO goes away, we're not necessarily done. There's a tail to the work. And then if you're moving towards the new model, there's an immense amount of work that has to be done starting now to be able to do it. So part of it's designing an entire global budget methodology for Medicare and then also for commercial, then also coming up with a regulatory structure for how you're actually going to regulate and let hospitals know what you're going to be doing. So there's a huge workload that would be coming to do that. So some of the people that are doing ACO work now, we would anticipate would be working towards that in this gap year. And then the additional positions that are in this presentation relate to that additional work.
Yeah, now,
Go ahead.
correct me if I'm wrong, but I think there are some agencies that are concerned as the one care model, exits the program, that they're going to are going to be losing monies for services, things of that nature. Between
Yes.
that time and the time that the head model comes on board. And there's some wrong, correct me, but there's some fears out there.
Yeah,
How are you going to address, if you can?
so there will be savings in having a gap year and there will be costs. So there will be places where there's less money and how much less money is to be determined. So the things I think you're referring to in the gap year would be Blueprint and SASH, 2 of the big ones. I understand the governor's budget has a fund there in his recommended budget to cover those, or at least big portions of those. And then the other big ticket potential loss of money would be money for primary care. I believe that's around $10 or $11 million. So if you're going to make up for a gap in funding, you need to increase Medicaid amounts, you need to get more money from Medicare, or you need to raise commercial prices. Or you need to lower it elsewhere and take it from there. I mean, those are your choices.
I think we might be conflating the board with the blueprint, which is in AHS. I mean, because, I mean, you regulate the ACOs, or you have review of the ACO's budgets, but you don't.
I think I can clarify. So the gap, we don't have money that we can give to the gap. That's not what the care board does. We regulate prices, we regulate budgets, but we can't create money for Blueprint. We can't create money for SASH, and we can't create money for primary care that we don't regulate.
But you have created budget for OneCare as they exit the scene, correct?
Yes, OneCare annually submits a budget and we review it and approve it or modify it. Yes, that is a regulatory duty we have, but we don't have a regulatory duty or money to send elsewhere. That would be the legislature or the governor, or we could increase commercial rates with a hope that it would flow through to places where there are gaps. We don't actually direct money either. So if we increase commercial rates, the insurance companies go and negotiate with everybody that they work with, and they determine where it goes. We can't say, you're paying all these people more money now. So we don't really have a mechanism to solve the problem you've identified, but I acknowledge it's a big problem. And it's one that does need to be addressed.
All set?
I'm not all set.
It brings up the issue of, because this has come up several times. And I'm thinking that we might want to try to find some time in the very near future when we actually have Blueprint come in to address the governor's recommend and what other organizations are saying it might be a gap between what actually is being lost and has it really been backfilled. So maybe we should get a better understanding from the Blueprint. Do you think that would be helpful?
You're the chair.
Cool. No, because I want to make sure that everybody,
I think
it's one of our largest budget
It's
items.
something that we should look into.
I think we probably should. Yes, thank you.
I was just gonna say, if it's okay, that I know you're short of time, that's a segue. Can I use it as a segue to my
Absolutely.
next piece? So that's a segue to our last line, which is the unknowns that are out there and as we're constructing this. I'll start with the last one, new federal policies and changes. You know, the previous discussion was assuming that AHEAD will move forward in a year. There are federal policies and changes. The other unknowns are the system solvency all the way across the board and system transformation. So we really grappled in preparing this budget with trying to solve for all the different scenarios. And the main message here is if AHEAD were to move forward, we would need 2 more permanent positions and then the other positions moving forward. And, you know, our other requests. So yeah, but our base budget.
Yeah, one other point, I think, Representative Page, you're right on about the concerns about losing money for very good programs. But you also have to consider in the context of what it takes to get that money. And if you go back to the last model, you had to take the ACO in a very expensive budget, and we had less Medicare money coming in ultimately during that experiment. So yes, you might lose 5 million here or 10 million there, which is very significant to incredibly important programs, but are you going to pay more to get that 5 or 10? And that's part of the risk that's being evaluated with the AHEAD model. It's a budget cap. It's a cap on how much Medicare will give us. Is that going to be less than we would have if we have increased utilization and run fee for service? So if we're losing money because of the cap, is it worth it to do that to get the money for these other programs? That's part of the dynamic and the challenge in this. So I think you have to think about it in the whole context of, and it is not cheap to do these models. The ACO was $12–15 million a year. This model, I mean, you can see how many positions we're, it's not cheap. So we're going to spend a lot to get it, and that's part of the evaluation.
Whether
And-
it's worth.
And whether it works.
And we're not the only expense here. You know, you're just seeing our portion here. You know, we're not the only expense in the state for this.
It's a 9-year commitment.
We do have, the state did negotiate good out clauses so that we can exit, which are, so we can exit better than we could in the last model. And the truth is, frankly, we couldn't exit the last model because of the politics, because of that money you're referencing. It would have been really difficult to take away that money because the model wasn't working and disrupt those really high quality programs. And we'll be in the same dynamic here, where if the cap isn't enough, it'll be very difficult to pull out money from SASH, which is a really, really beloved and successful program. So that's part of the challenge with this.
And do you eventually decouple
Right.
those expenses from the program?
So, well, no, it's just, there are so many unknowns.
Yeah.
And I totally recognize that, which, you know, in my head, I'm thinking about all these unknowns. So in fiscal year 26, you need 2 additional positions for a head. We're working on the budget right now at this moment. We don't even know if we're moving ahead with a head. So, so what happens if we fund 2 additional positions and then all of a sudden in May or June, we like, oh, well, that was the end of a head.
I would defer to the experts, but I would say they would be contingent on a head moving forward.
So I can speak to that a little bit. So
Yeah.
2 things. Yeah, so the federal government is in an administration change, and where they stand on this model and the deal that we've negotiated, we don't have great insights to. We do know that they've been changing some of the personnel in that office, and we'll see where that lands. And we don't have really good insights into where they're at right now. We presume that they're still supportive because we all signed the agreement. So yeah, I would agree that if the model doesn't go forward, we shouldn't be asking for the 2 additional seats. With a caveat that there is a outline of a bill in the Senate Health and Welfare with significant other additional work, right? So there's a plan for a division of planning and coming up with a statewide strategic plan for healthcare, which I do think is imperative. I think that's actually money really well spent. There's also discussion of global budgets outside of HED in that bill. There's also discussion of reference-based pricing in that bill, right? So none of these things happen without people. You can't just implement reference-based pricing with nobody. You need people to do it. And HED has multiple streams. So you would have a global budget for one hospital participates in the first year, but they would also be on fee for service with commercial, or at least many commercial payers. And then their professional services wouldn't be in it. So it's not like there's an easy alignment. You're actually adding more regulation and more discontinuity within a budget. And then in the second year, you might have only 1 commercial payer and 10 others that are not. So the complexity of regulating and paying it's very, very high. It's a high degree of difficulty. Again, that's another unknown. Like if a hospital signs up, it's a voluntary model. Do any hospitals want to do it? I've heard some interest, but they don't have really good data as to whether or not this will be financially beneficial to them. So the unknowns are massive. There's no sugarcoating.
And can the hospitals get out of it if they sign up for it?
I have to go back and reread it. I don't have the answer in my head. I think they probably, I shouldn't commit to an answer because I don't know. But if the state doesn't have a hospital in it, the model terminates. And by year 2, we need 50% of the Medicare money in the model. That's the second year of the program. That would include, that's a lot. UVM is, I think, the network hospitals are 63%-ish of the system. So you'd have to have, I think you'd have to have UVM in by year 2, or the model will terminate. So if they don't want to sign up, it's not going forward regardless of what you want, unless the state determines to mandate it. Either the care board determines to mandate it, which I'd be shocked if that were to happen, or you determine to mandate it, or the governor does it. And I think given the unknowns, I wouldn't anticipate people are ready to do that yet.
Awesome. Just curious, what do you mean we mandated? How do we, I didn't know that we had any access.
You would pass legislation mandating hospitals participate,
Just,
or we would have to do it, or the governor, somebody.
I didn't know we had access to that.
We'll pass it on
That's
to you.
I would not anticipate as of today that we'd get 3 votes to do that.
Or
I'm
more
not
than
sure I
6
could get
votes
11,
here.
or I'm not sure I could get.
Or more than 6 votes here.
We'll pool it.
You will, you only need to get 3, you'd have to get 6.
Not enough.
Oh, wait, there's a downstairs too. You had in your original introduction to us, a couple proposals being relieved of your duties to oversight over Vitals budget. Is that, and I'm sorry, I haven't had a chance to read it, is that in legislation that might be in the other body right now?
It is, I believe it's S63.
Okay. And in there, you also had a proposal around a more collaborative relationship with VHI. Is that also in there?
That is also, I believe, in S63, yes.
And if you're relieved of reviewing Vitals budget, will that lead to any savings? I'm assuming that
We do not
person
investigate.
will be
That's not,
reviewing other budgets.
yeah, that's not an FTE. There's,
Yes. Okay.
but also the board members have a significant, it's not just the staff for us to take 2 days to read it all, work through it all, and we don't really have a big impact on that budget.
Okay. So in summary, you support the governor's recommend with what additional?
We support the governor's recommend, and so back up one piece on the HEAD model. The board voted to support it and sign it with some contingencies. We had difficulty getting 3 votes. And so we conditioned the vote where it's an automatic termination. I, as the chair, am required to send a termination notice of the model if certain conditions don't happen. And those would be including appropriate staffing to do the model, which is 5 people in year 1 and an additional 15 in year 2. So if we don't get the seats necessary to do the work, I will send in a termination. I think it's September 30th of this year. Another one was we had concerns about some of the funds flow with the network in New York hospitals. And one of the conditions was, I forget the language, but something around directly or indirectly financing non-Vermont hospitals. So if that's not repaid, or if a hospital participates with that kind of debt situation, I would also be required to terminate the model. So this creates obviously more unknowns, but in our view, the model, I couldn't get 3 votes otherwise. And the model won't work if you can move money out of state. It won't work. And it also won't work if we can't monitor for access, because if you get a chunk of money, there's less requirement to see the patients to get the money. So with an access problem, that's something you really, really need to closely monitor, and something board members were concerned about, is the difficulty getting into providers. And fee-for-service actually encourages access.
So of the 5 positions which are contingent upon the HEAD model moving ahead, or not, you not terminating it, then the governor has authorized 3 in his, but you would have to have an additional 2 in FY 26 or September,
Yes, correct.
you're terminating it.
Correct. And the 3 that the governor put in weren't specific for a head. They were just general for the work that we're doing.
Okay.
We actually have a couple of slides. Jean, do you,
Yeah.
did put together, there's 2 slides that are maybe useful to the committee. So actually go on, Jean. This is our budget total appropriations from 18 to 25, you can see we've been pretty flat throughout time. And that's by design and intent. But the workload in healthcare and some of the responsibilities that we've been given by the legislature have increased, right? Act 167 was a tremendous amount of work. No additional staff, not one, in-house to do the work. We're contractor dollars. We've been, go down. If you compare, so this actually a couple more.
Okay.
Yeah. So this is some of the various possibilities that are out there that are being discussed for future work in healthcare at the board and others. So quality and access are two main drivers of our work. We do not have any dedicated staff to quality or access. So we have 3 people on the health systems finance team that do 14 budgets worth now approaching $3.7 billion in 3 months with immense complexity in those budgets. I mean, there's a lot of rabbit holes in those and it's huge. So you can't review the financials and all that and also come up with a quality framework and an access framework, which we see signs of deterioration in the state in those areas. So we do think that that's worthwhile. And with the 3 positions the governor has appropriated, we would use, or not appropriated, that he recommended, would be quality and access would be 2 of them, which we think is really important work. With a head right now, we have 1 staff member currently dedicated to that project and working on it. And then there's discussion of reference-based pricing, rate setting, the division of planning, potentially reverse CON, all these other concepts that are out there. I think as a state, we need to pick what we want to focus on and do it well.
Ellen?
How'd you come up with 20 if we don't really know how HED is going to work?
Good question. I would say it's hard to estimate the number of people for something that you've never done, right? So we spoke with Maryland, who has been doing global budgets, and we got a sense of their org chart and what they have. I believe we have a slide on it. They might have, I think they have 50 or 60 people working on this. It's a bigger state with more hospitals, but they've been doing it for 30 plus years. So they've got it down to what it needs to be. Yeah, it's 60 people that the Maryland Health Service Cost Review Commission has for that work. So we looked at their org chart and we did the best we can to estimate. Now, is it 15 instead of 20? Maybe. Is it 40 instead of 20? Maybe. But 20 was what we thought was the best, the most accurate, based on our conversations with understanding what we have to do with that. And then the Massachusetts Health Policy Commission, they have 174 staff members. And the PUC and PSD, which are probably the closest analog here in Vermont to the Care Board, that's 2. They have a division of planning and the advocates kind of office, and then they have the board. But we kind of do both. But they have a staff of, I think it's 83 and a budget of 18 million for energy. And the board, just to put in perspective, has a staff of, including the board members, 37, a little under 9 million.
And I want to say part of our budget, $500,000 goes to pay for the healthcare advocate, goes for our piece, $510,000 of our budget goes to pay for the healthcare advocate. We also are stewards of the VCures and FUDs databases. And so those are substantial, substantial portions of our budget as well.
And also the LPAR model had significant contracting resources required to do the work. A contract, I think it's nearly $1 million for one contract.
Yeah.
So that 8.8 covers that as well.
Leslie? I get that it's not apples to apples, but I'm just curious about the energy sector and the size of the energy sector compared to the healthcare sector. And I think you said 3.5 billion for healthcare. Do we have a sense of what the energy sector?
I think Vermont healthcare, the whole healthcare industry is probably $7 to $8 billion now.
Okay.
I'm going to guess it's around 20+% of GDP, but we don't regulate all of it. So the hospital sector is about $3.7-ish billion, which we regulate, but then we have the ACO work and the other work. The energy sector, I think it's comparable-ish to what we regulate. Yeah,
I didn't,
around 3.6 billion.
so it is comparable and you get at least double. They get a lot more money to do it. Kind of people.
Yes, and it is, this disclaimer is worthwhile.
I get it.
It's Not.
I hear it. I started with that. I know it's
Yeah.
okay, but at least it's a
It's context.
Yeah.
This is the best we could come up with context for this. And the healthcare costs are really rising quite a bit quicker than energy.
Okay. Yeah, but
I have another question regarding the ahead model. You talked about signing on and your criteria for signing on. The last item was related to monies, Vermont monies going to New York State. Kind of getting the evil eye.
No, I was listening intently.
What if some of those hospitals on the New York side go out of business because they no longer can rely on UVM Health Network? And those individual patients then, take the ferry across the lake to UVM. We're still going to be putting Vermont monies into New York patients, which I understand we have a positional duty to do that, but in some ways, we're not going to be any better off, I guess. UVM's probably going to have to maybe create more beds, bring in more doctors and nurses. We're not going to be any further ahead, I think, in the end.
There's a lot beneath that question and nuance to it, but so I think that potentially you would be, because you would have more investment in economic growth and investment in Vermont as opposed to in New York. I would hope that the New York hospitals always remain solvent.
Well, we all do.
But part of that is for the New York insurance companies to pay an adequate amount so that that doesn't happen, and for Albany to pay an adequate amount so that that doesn't happen. It shouldn't be Vermonters' responsibility to pay those bills. We don't pay the bills for New Hampshire. Are we going to pay the bills for New Hampshire if Dartmouth gets in financial trouble or not? So I would hope that Albany and the New York insurance companies make it financially solvent for those hospitals to stay and do well.
And is New York insurance companies, health insurance companies doing well?
A lot better than ours. And they have many, 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 many more. And they have a much bigger footprint with the Uniteds and the Cignas, who have enormous, enormous reserves, right? We are overwhelmingly Blue Cross Blue Shield in Vermont that is not, as we all know. So yes, they have much more tolerance for the New York insurance companies to pay more than ours do. And the people in New York have much more tolerance to pay more than our people do.
I have one final note. You asked about our thoughts on the governor's rec for the 3 positions. They gave us pool positions, which there's a process required to request them from the pool. That can be time constraint. Our preference would be to have them in statute, because we might run the risk of missing the September deadline. I just wanted to share that.
okay, we will make note of that.
I don't really know what that means.
Go ahead.
So positions from the pool, what that is an agency or department can request from the administration a position exempt or classified. And then there's a body in the agency of administration that reviews your request and makes a decision on it. If it's a no, it's a pretty quick no, but if it's a yes, it could take multiple meetings while they figure out how to balance all the requests, because there's only a set number of pool positions as determined by the
There
legislature.
could be vacancies and they can go back to a pool, and then the pool and the agencies can come and apply to the pool for one of the open positions. And then the administration, Secretary of Administration, and the governor's office would then say yes or no. And the governor
Say
put this.
yes, it means you get the position for X amount of time. Does that work?
Yes.
Yeah.
Yes.
I think that's how we got Diana.
And that process is, I mean,
Works well.
It's still swimming.
Daisy, is someone from your office going to send us a suggested language?
yes,
Thank
I'd
you.
be happy to.
So while you're here, we're actually pivoting to, we're gonna do some markup on the CON bill. And I wanted to make sure that we asked a couple things, because it's been a while since we had you in on this. We've had, so you had mentioned fees. So if we increase the thresholds, that means that you will have less people applying for a certificate of need. When people do CON applications, they pay you, the board, fees to offset those costs. But clearly you will have less of those fees. Is there,
Finish.
I think you're reading my mind.
Yeah.
Is there going to be a fiscal impact at all? Do you feel, to the board and your budget?
I don't believe it would be considered highly material. So it's the fee is 0.01. The fee is a percentage. And I'm not going to get the percentage right. It's like 0.00125. I just have to do the math in my head, but long story short, it's capped at $20,000. So the most, like all the work we did on the like UVM outpatient surgery center, or say the Southwestern Vermont Medical Center mental health unit, like those are all capped at $20,000. So, and we don't get a lot of $20,000 requests in a year. So, so it's not immaterial, but it's also not something that's gonna break our budget, if that makes sense.
Great. And speaking of the Southwestern Vermont Medical Center, there's, I don't know if you had a chance to look at the bill, and I think we may have touched on this when you were briefly here. We have the exclusion of healthcare services, construction, development, purchase, and renovation, or other establishment of a healthcare facility as the result of a contract awarded by the state of Vermont. And I do know that the Agency of Human Services has suggested some additional language, which I don't happen to have in front of me right now, but it suggests, or state facilities owned by the state in addition. And I'm curious, you've done CONs on some of these before. The Southwestern Medical Center is one. Do you see that process as being duplicative of what has already happened, you know, through the RFP process, through, you know, the legislative appropriation? Do you see that the process of what you're doing is duplicative of what has already been done? Or do you, when you are reviewing certificate of need, do you focus on things other than what would be focused on, say, through the RFP process?
So I'll start by saying that we would support the exemption for state awarded contracts. It's not necessarily perfectly overlapping, right? Some of what we do and how we do it does get a little bit deeper. But to be honest, it's really awkward to review something that you all or whoever has approved and put money forth. I don't really want to say a project after the legislature or DMH or whoever has determined this is something that we need. We do have a little bit of a different lens on it, which is what's the capacity elsewhere in the state and healthcare spending kind of writ large, and the financial feasibility of the project. So if the project is not financially feasible at a nonprofit hospital, what can happen is if they're losing more than they thought, they'll need more money, most likely from the commercial payers, which is a problem. So we might take a bit of a different scrutiny, just a little bit. Having said that, I would approve exemption for state projects. The only wrinkle to that, I would say, is what qualifies, I forget the language, but it's a state awarded contract or project. Let's say the state awards $1 million towards something, and it's a $150 million project. Is that exempted? Because that's very, very different than like the SVMC example where the state put up, I think, the full $10 million, right? So that's just, there could be a little nuance there, maybe just to flag. I don't think we'd support exempting a $150 million project with like a $500,000 state grant or contract. So
Thank you for flagging that. I don't think that's been mentioned at all, but you're right.
yeah, and
Is that something we really want to do just because the state put a little bit of money towards something?
right. So just the definition, I forget the language, but state awarded or whatever it is.
Okay,
Maybe a little clarity on that might be good.
all right, we can work on that. Does anyone have questions for Chair Foster or regarding the CON? Or
I don't have a question, but would it be possible to have you send us something in writing about the fees and that you support the bill, even though, you know, that the fees are, what's the word we use?
Oh, immaterial.
yes.
That-
I was hoping for de minimis.
De minimis.
It didn't go there.
Sorry, I clearly need to buy a vocabulary day of the month, day of the word, you know,
Exactly.
calendar to improve.
But if you were comfortable with that, that would be great.
Yes.
You can do that.
Absolutely. Alan, you had questions before on. I did want to ask because there are some things that we had been discussing. Regarding the issue around enforcement, hospital budget enforcement, on whether or not you would be amenable to receiving authority to review cuts that were being made in response to enforcement of budget orders. And, I mean, I think I keep conflating it with certificate of need, but it's really not. It's more in your authority over hospital budgets. Is that something that you would, do you have any opinions on that, I guess? Or is that something you don't want to do?
So it's complicated. I think that there's current issues that are raising that to be a more clear potential issue. In the past, we've had budgets, and it is a hospital and their board's job to manage their operations consistent with their community's needs. And I think that they've done that generally pretty well, right? We don't really want to get in the business of micromanaging everything a hospital does. However, I think, the UVM changes were what everyone is thinking about. And those were difficult to see aligned with state goals of improving primary care and mental health. So I think in that instance, it would have been better to have had a level of review. Generally speaking, I think that the hospitals work within the budgets pretty well. I think this one instance is sort of catching our attention. So how we would draft that, yes, I think that we should have reviewed that. It is a complicated thing to review, right? In our budget orders, we do say, hey, here is why we don't think that you need this much money, and here's where we think you can go. But some of it's not that easy. It's not like you just have money necessarily. Some of it's like operations. Can you move patients out of your ED to your primary care? And we see data that says or suggests, yes, you can, and that will lower your revenue so you could keep a service and not have to cut it. Are we right? Can they do that? We should definitely push for it because that is something we're trying to do. So I think generally speaking, the answer is yes, we would support it, but we'd want to think and talk about how to craft the language right. I think it's a little bit tricky.
That might be, I mean, I do realize that the other body is working on some things that come into, and perhaps if and when something comes over here, we can talk about putting some safety mechanisms in that. that what you're referring to as the reverse sale? Well,
Yeah,
that's,
I know.
I'm just thinking of it in my head. as-
Yes.
So some states do have reverse CONs, but there's also like a threshold. What qualifies for whether it's budget enforcement or budget implementation or reverse CON? You know, we have a lot of small hospitals. If two doctors retire, does that trigger a review? And we can't say no, they're retiring, right?
Mhm.
Whereas, you know, other situations could be viewed a little bit differently.
The idea more about service lines, not retirements.
Service lines can go away with a
For
retirement.
sure,
So, yeah.
but there's not much you can do, but if the
Right.
hospital decides to shut down their OB, make
Right.
something a little more.
Right. I think we all know what we're sort of getting at. I think the answer is, yeah, we could review that. I think what you do, so in the outline of the bill in the Senate, they have a statewide strategic plan for health, and we're supposed to review budgets consistent with that plan. So if the plan is improve community providers, improve mental health or primary care, we would review a service line change like that for consistency with what we're doing as a state. So that's another way that starts to get at that issue.
I think the other issue that that had come up in testimony was that the CON process has caught in the past certain facilities, medical providers offering services, non-evidence-based, and you know, the fear is if we raise the thresholds, that those particular things would be able to come in and Vermonters would be hurt, or maybe if not hurt, being sold of services that have no basis in good care. Is there general support, I think, from the board in maintaining a jurisdictional process like you have now? That perhaps you would have the authority to say, yes, you're not coming up near the thresholds. However, we would prefer a CON process on your project because we don't know what you're planning on doing, or.
Yeah, so essentially, I think what you're getting at is sort of if there's red flags of concerns about the organization,
Yeah.
we would that would trigger a review, that kind of concept. You will have a lot of projects under a 10 million threshold that we would never review. So to do that, you'd need a mechanism, and the best I can think of would be every project would then have to submit a letter, or you'd have to have a threshold for who's got to submit a letter. You know, I presume people, if they're, you know, up to no good or it's junk science or whatever it might be, they're probably going to word their letter so you don't catch that very easily. So we'd have to think about what the process is to require the letter, and then also what they would have to disclose. Like I could see something where you have to disclose, have you ever been fined by Medicare? Have you ever been investigated by DOJ, or are you an attorney general's, you know, things like that. There are things that can sort of trigger, hey, maybe we need to look at this. But we'd have to work on that. I hope that that's not something that happens too much here. There was one or two we've kind of caught in the past that didn't look like they would be beneficial. I don't know that's a huge raging problem. I hope it's not.
Stem cells.
Well, we did a whole stem, but that's just one thing, but there's other things like that.
Right, real whole stem cell.
Yeah. Or like yeehaw or something like that.
Yeah.
Oh, yeah.
Yeah, it was.
There have been a couple that we rejected.
Yeah, I just. You know, I mean, I think the fear is if we raise the thresholds as significantly as we are, then we're not gonna cap, and would that encourage people to come in and do that because they know that there's not gonna be any sort of oversight whatsoever?
I mean, I don't know if it'd encourage it. I mean, this is all a little bit theoretical, what I'm saying, but I mean, Vermont's not a huge market in the first place. And there's other states with no CON or higher thresholds. So I don't know that Vermont would necessarily be disproportionately targeted with this change. But there could be a process where there's letters under certain thresholds and triggers and disclosures you have to make.
Okay. We can talk to our legislative council and see if there's something we can do around that. Any other questions? Thank you for coming back. Thanks for coming in. I feel like the board has been in here a lot this this year so far.
Appreciate the chance to be.
Thank you.
Thank you.
Yes.
Good luck on the next.
The next
Yeah,
one.
next meeting.
Yeah, you want to join us?
Ally, welcome.
Here.
Oh, it is
Oh,
on.
it's on.
This-
It's not our.
No.
That's right.
They have some question. Leslie. Sorry.
Yeah, they've really been.
We're still in seeing, they're on lock.
Yeah.
It's getting towards Friday. Shouldn't sound like thunder today.
Right.
Oh, yeah,
We're evolving.
You can go ahead, yes.
Good afternoon, Jennifer Carby from the Office of Legislative Counsel. I do have language I've just been tweaking a little bit as we were talking. So I don't know if you want me to send that Kristen to post, or if you want to work on it and then,
Do you want to share your screen or no?
yeah, no, I'm happy to share my screen. I just didn't know if I had realized I hadn't sent it.
Yeah, and we could have Kristen post it and
Let me send it to her first.
I think she posted the as introduced.
Just literally sent it to you this second. Okay, but meanwhile, I can put it up in the screen. There. All right, so we're looking at a potential strike all amendment to H96. I have shown the changes struck through or bold for what's being proposed to be removed or added, and then I've highlighted all of those changes as well. So the first one that you have talked some about is changing this includes to means, so that a healthcare facility other than a hospital, and the same language in the hospital, could not develop or have developed on its behalf a new healthcare project without issuance of a certificate of need, CON. And for purposes of this section, a new healthcare project, and it would say means any of the following as opposed to includes the following.
We felt like includes meant it could include anything else.
Right, includes means pursuant to Title I, including but includes but is not limited to. So, so this would have a static definition, and then you change some of the numbers, not this first one. So this has construction, et cetera, with a cost of more than 10 million, so an increase from 1.5 million to 10 million. But for a piece of diagnostic or therapeutic equipment, the bill as it was introduced would increase from 1 million to 10 million. You have discussed 5 million. And then for the offering of a healthcare service or technology with an annual operating expense, and under current law, it's 500,000. Again, these existing ones are all slightly indexed under the board's authority. The bill as introduced said 10 million, and this would change that to 3 million. So a service with an annual operating expense that exceeds 3 million. And then we get into the hospitals, and again, this changing includes to means any of the following. Still that increased to 10 million for construction, and then 5 million for the piece of equipment, and 3 million for the offering of healthcare service or technology. And then leaving that 50 million for the conceptual development phase certificate of need that was in the bill as introduced. So I think that's the changes to all of the numbers. And then exclusions, we talked about putting in exclusions that were included in S10, another CON bill that's in the Senate. And so that would exclude routine replacements of medical equipment that is fully depreciated. And then it keeps the language around non-medical equipment and fixtures, and I've just added regardless of their remaining useful life. So it's clear that that depreciation piece only applies on medical equipment. And then just adding some conforming language. Then we had talked about something that is the result of a contract with the state. This includes a few potential revisions. So it still starts out excluded from this subchapter are the offering of a healthcare service or the construction, development, purchase, renovation, or other establishment of a healthcare facility. And the first change is to add that is owned or operated by the state of Vermont. So that was a request from the Agency of Human Services. And then based on your conversation just now with Chair Foster, I put in as a potential place to start, instead of as the result of a contract or grant, I said is funded in whole or in substantial part by a contract. And then AHS had suggested adding or grant. So that's in there as well.
Questions about it, Leslie?
I do, but I don't know if it's for you or Brendan.
I think we're gonna have AHS, I think we could ask now.
I'm curious to know the contrast between the work that is done for a project by AHS as opposed to the work done by a CON. Does it take in the community need? Does it take in surrounding topography? I think the CON process is very focused on that kind of work. And I just didn't know if that was part, community input, all that kind of jazz. Do you do that too? And I don't know if you want to answer that now, but that's my question, the contrast between the two.
Thank you for the record, working with the Agency of Human Services. I think I'll let my colleague, actually John, staff attorney for the agency, address that question. And I think you can do it now or during your brief testimony, whatever would work best for the community.
I will have her come up if you,
Whatever you.
let's see if we have any more questions for Jen. And then we'll have.
Right, so there's
Ashley, right?
Yes.
Yeah, and we'll have Ashley come up.
So there is one more exclusion that comes from S10, and that is to exclude from the CON chapter emergency and non-emergency ground ambulance services, affiliated agencies, and equipment and supplies used by emergency medical personnel. And I've used some, piggybacked on some definitions from Title 24, where there's the ambulance service language. And then finally, the effective date. The bill as introduced had an effective date of July 1st, 2025. We had talked about how this would be implemented. So as a place to start, I look back at some previous CON bills and some that became acts. And we used, in some cases, language like, and shall apply to all new healthcare projects initiated on or after that date. And for applications for a CON that are already in process on July 1st, 2025, the jurisdictional thresholds and exclusions in place at the time the application was filed shall continue to apply until a final decision is made on the application. We're not changing anything that's already in process.
So if they've already applied, they still have to go through it.
Right.
Starting July 1, any new application.
Right.
One does wonder if you could withdraw your application and reapply.
You have to ask the board. I don't know how that process works.
Would have to ask the board.
Yeah.
Does anyone have any questions for Jen? Any questions, concerns on anything currently in the bill? Any suggestions?
Just trying to reread the suggestions we got from the Green Mountain Care Board. The Word document
The one that they had sent
yesterday.
yesterday.
Emergency services are exempted and the air ambulance is already exempted.
It looks like again, Martin,
What's
the
that?
emergency service.
Someone had asked about air ambulance
Oh, yeah.
requiring CON and they replied it's already, they're already exempted and it's under the emergency services.
All right. No questions. Thank you, Jen.
Sure. I'll be right back.
Ashley, did you want to join us?
Chair Black, Committee, thank you for having me today. My name is Ashley Johnson, Staff Attorney for the Agency of Human Services. I'm happy to answer any immediate questions or give a brief overview and then answer questions, whatever is most fruitful for the committee.
I think, well, to Leslie's question, the thoughts around the RFP process, what the criteria that the state looks for when approving or, putting out an RFP for something. How do you think that is different from what the certificate of need is looking for through the Green Mountain Care Board? Can you go into the process of how the state chooses to invest in services or facilities?
And I think that every project's going to be slightly different, but I will say that if the state of Vermont, especially the Agency of Human Services specifically, is going to fund a project, we're looking at that need before we agree to that funding, before we go through that RFP process. I imagine that's why the board is not opposed to an exemption for projects like that. We do have 3 projects that I have as examples recently. There was the BART Hub facility in Bennington. That project actually went through a different CON exemption that exists in statute already, related to the PHIP, which pursuant to our waiver is DEVA. So if we can connect a program to DEVA and DEVA has done that analysis, it can be exempt under that already existing statute. But our other departments who are going through identical processes don't have that exemption level. So they do end up having to go through the CON process unless they can find another reason to be exempt. The Brattleboro PRTF facility is an example of one that we didn't believe needed a CON, then we thought needed a CON and ultimately did not need a CON. So there's just a lot of back and forth about what those requirements are and whether or not we're appropriately meeting them. And I think the committee already talked a little bit about SVMC, the Southwestern Vermont Medical Center, which is going through the CON process and I think has been in that process for about a year.
Go ahead.
So what I heard you say, let me just make sure I got it right. Let's take the CVMC thing. We know that was a failed process. So can we just stipulate that we didn't like it? And that's
Which one?
Reddington. The Bennington project.
The mental health.
The PRTF.
So it keeps coming up, but I think it's a diversion because it wouldn't come up in this new model, right? True. No, now, but in the new law, with the new law, it would not, because it's under 10 million.
It's 10 million because of.
Well, whatever, but the point being, what I heard you say was that you would do it on financial analysis.
Did you do a financial analysis? Yes.
But I'm curious to know if you go beyond that. do you go into the community? Do you get feedback from the community? Is there testimony? Is there looking at topography, as I said, wetlands, whatever might influence? I think that CMN takes that into account. And I'm just wondering if you take that into account as well.
I can certainly say that the Agency of Human Services is consistently looking at equity and how we are, especially geographically providing those services across the state of Vermont, how each department determines that need and whether or not they've gone into the community or sought those commentaries from the community. I can't speak to without actually getting input from the departments who handled those projects, but I can share that subsequent to my testimony after I'm able to talk to my colleagues.
So it sounds like it's distributed through many departments, that there's no overarching sort of oversight of the project, perhaps, from the different departments, whatever different agencies might be involved.
So they would always come up to the Agency of Human Services, right, to the secretary to have that overview of what's going on. But the individual actions the departments takes to make that proposal, I can't speak to without getting that information from the specific department. Specifically, the thing I'm thinking about is going out into the community. I don't know how they are asking for community input in each individual project.
Go ahead, Jason.
Do any departments have committees of stakeholders that review RFPs before they go out?
I don't know the answer to that question, but I am happy to find out.
I believe that is true, and not in every case, but in some cases for sure.
And I'm not going to just I have a bunch of questions. Do any departments put RFPs up for public comment?
Before they're bid out?
Yes.
I would look to Brendan to see.
I'll have to follow up with you. I want to make sure I get the right answer for you, but we can follow up with a memo to the committee or an email if that's helpful.
Okay. Or I guess I could just go Google AHS RFPs and see if there's anything posted. But I think that's what I was certainly curious about last time we were thinking about this, is what opportunities there are for the community or the general public to sort of weigh in and also be educated about the project cost and benefits. I know there have been projects close to my area. The facility in Essex is what I'm thinking of. And I know that when that was being planned, we were able to see maps of it and be educated about it and weigh in. And I found that was really nice.
Who was running that? That was
DMH, Riverside?
River.
Yeah.
River Valley.
River Valley, yeah.
It's River something. Is there evidence that the current CON process as currently configured is a deterrent for organizations, facilities, whoever actually responding to RFPs?
I think that's the fear, that having such a long CON process, we do hear from community members in other areas or stakeholders in other areas that this process is long and costly for them. So having that deter their participation in projects, if it's already a state funded project. I'm thinking specifically of a project that if the legislature mandates project, that need has already been studied. AHS is under a mandate to complete that project. So we have already studied that project. I'm not sure that having a CON process on top of that adds any knowledge about the need for that project or how it's going to proceed if all of that pre-work has already been done. But it does delay the ability to stand up the project and have that access for Vermonters if we're going through a subsequent CON process.
Does anyone have any concerns? The language that Jen had read through, it was the suggestion of AHS to add the portion that says that is owned and operated by the state of Vermont. Does anyone have previously it had been contract or grant awarded by the state?
Still has that.
Still has that. It's an and. Okay. Thank you. Thank you. Thanks for coming in. Yeah.
Thank you.
So I am putting this out we're gonna vote on this tomorrow. All right?
We waiting for language from them on agreement and care board?
I,
You had asked for language when they were just in here.
yes, and I think the thought is that it might fit better somewhere else because it's technically not part of the CON process, but at least we'll have language to that effect. Okay,
So not related to the letter they sent yesterday.
yeah. I'm sorry, did I miss something? Was there language that,
Is there a letter? I don't know.
There was a letter this,
There's a memo.
I think there
they
was.
sent yesterday that there was a spreadsheet.
Suggestion table.
Sure, I'll call it that.
Oh.
It's in green. Yeah. So, they listed the health first suggestion, work that's being done in S10. And recommendations from the HCA's office. And then there's a column for whether they agreed with it or not.
What page is it on?
It's in an email we got yesterday.
It's got it in front of me.
Kristen sent it.
Today's
Kristen,
Owen Foster reform suggestion
It looks
table.
like this.
It's on our website.
And then there's a Word document that goes into much more detail.
Oh, I see it. It's the first two, 346. Con reform suggestion.
Is this on our webpage?
Yeah.
it is.
Today.
It's posted under Owen Foster, H96 CLN reform suggestions table.
I just wanted to, do we know that the Green Mountain Care Board's recommendations have been incorporated?
They were a little hard to, it was a little hard to understand what they were actually saying in some of that, so I think like the monetary thresholds, yes. I don't know what strength and affordability standards means.
I'm not sure what that means. That was something that the healthcare advocate had pointed out. I do not remember the committee discussing that at all.
That was really going just.
I think the bill as is, we've changed the thresholds and we've added the exclusions. That the board, and other than that, I don't believe we've changed anything else.
So there's no review of projects between old and new thresholds?
No.
Okay,
That was the effective date version, right?
Yeah.
I mean, yes, effectively, we dealt with that.
We dealt with that with the effective dates. All right, so we're gonna vote on this tomorrow after floor, so. Just want to encourage everyone to be here.
I'm getting my little sheet ready.
Okay. I think we're done for, okay, so we're done for this afternoon, but after the floor, we're going to come back. So if everyone could be here 10 minutes after the floor, we're going to finish up with our witnesses from earlier today because they deserve our
Came a
time.
long ways.
They came a long way. They are gonna be on Zoom. So they're gonna go back, they're gonna go back a long way and they're gonna join us on Zoom. And we weren't able to get to them after our joint assembly today. So